This episode of The Benefit Whisper is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget. Employers are spending more than ever on healthcare, but they still can't get the employees fast access to care. So what happens when you bypass the system entirely? Today, we are speaking to a founder who's doing exactly that and just went public doing that. Welcome to the Benefit Whisper. I'm Ralph Weber, and today I am joined by Dr. Paula Muto, founder of UberDoc, now since about a week ago or so publicly traded and rethinking how patients access specialists. Paula, great to have you here. Welcome to the Benefit Whisper.
Well, thank you, Ralph. It's wonderful to be here.
UberDoc is fascinating to me. And correct me if I'm wrong, but is it kind of like OpenTable, but for doctors? Tonight I want sushi, tomorrow I want pizza. So you can kind of just pick and choose what you want?
Exactly. I'm a surgeon on the front lines, right? Whole family of surgeons,
Right.
and run my own practice. So I saw how crazy it was. Patients oftentimes had to ping pong 3 different places before they came to you. Sometimes they were out of network, in network, all this nonsense, and everyone was losing. The doctors were losing because they weren't getting the patients. The patients were
Right.
losing because they were spending a lot of time and money in places, and they weren't getting their problem solved. So I said, what if I did something really simple? Really simple. Just created some type of platform, a web
Right.
application where you could find a doctor nearby and available, make an appointment by pushing a button and see them. And in order to do that, you had to take the insurance piece out of the equation, remove the middleman.
Okay.
But what if you made that price affordable? Like, in other words, make it real, make it so that people could afford it. So basically, we flipped the equation on access and affordability. So that's what it was. That's exactly what I decided to do with UberDoc. Is like, so I asked my specialist, could you put a couple of seats aside a week in your office for a direct pay patient?
Right.
It's like, think of it like, I like to think of it as an OpenTable or even like a Ticketmaster, right? Like, in other words, like, you think about a show, the way shows always have 2 seats aside for critics. Every
Sure.
Wednesday matinee, there's a couple
Yeah.
seats. They either sell or they don't sell. That's how I always thought about UberDoc.
Right.
And so that's what we did. And I just started in my surgeon's lounge and then expanded to more and more. And next thing you know, thousands of doctors across the country in every specialty, and every geography, in person, also telemedicine. We have some of the best specialists on our platform who believe in this direct pay model and believe in access. So it's really about, like you say, getting the patient in.
Wow. That's cool. And obviously you saw something missing in, traditional healthcare. I had a 6-part mini series on the last 100 years of healthcare in the US, what it is, what it was, and it has very little, as you know, what people define as healthcare has very little to do with health or care. They're actually 2 different things. There's the medical care itself, which is great, but then there's the financing part, which right now is a mess. At least it's not doing what it's supposed to. So what did you see in that part that you thought needed fixing?
So it's interesting you say, this medicine and this healthcare, right?
Right.
So they should be overlapping circles. They should be the same. And
They
now
should.
they're separated and now they're
Yeah.
completely apart. So the business of healthcare and the practice of medicine are completely different. And so what are we funding? Right? What
Well,
are we funding?
if you're asking me, I'll tell you we are funding confusion, opacity, and friction.
Right. And I think in the old days when we all wore white coats and in the 1960s when the doctor knew what was best for you
Right.
and you go into the hospital, right? There was no other
Yep.
place to go. You went to the hospital. And I think in those days, it's sort of understood that everything was centralized and it became very expensive and so forth. But with technology and with the age of the internet and the ability to access information, patients just have more access to information and and they participate more in their care. I mean, look behind me.
Sure.
I do a lot of vascular work. This
Yeah.
is all in the office now. I used to be in the operating room for hours with this. I'm in an outpatient setting or my office for 15 minutes. Now, what does that mean? That means that my skills are less? Well, no, it just means the technology has given me an opportunity to treat a patient very differently. But their recovery is going to be at home. It's not going to be under my watchful eye anymore. So
Right.
with this changeover of more and more patients sort of coming into the hospitals with their
Hmm.
technology, then going home to
Hmm.
recover,
Right.
the healthcare dollar remained in the hospital,
Hmm.
not at home with the patient. And I
Okay.
think the fundamental shift that's occurred, and the reason why medicine and healthcare are in two different spheres, is healthcare is still funding that 1960s, the doctor knows what's best for you, come in the hospital for a week and
Right.
roll and recover model,
Yeah.
right? I think we have just not moved forward in
Hmm.
terms of where healthcare, where medicine and technology has brought us. And we're using a
Sure.
sort of a clunker of a system
Interesting.
doesn't fit the way we practice anymore. I don't like to go backwards and say we did it wrong. I think we did the best we could with what we had, but things
Yeah.
have really changed so quickly. The healthcare system has not caught up.
Yeah. No, I couldn't agree more, Paul. It's amazing. What do you think employers are getting wrong about healthcare access today?
Well, I spent a lot of time learning about the employer space. One of our
Mhm.
advisors, and actually one of our board directors, Jeff Hogan, was great, and he
Mhm.
really taught me a lot. But I've been really out there because I said, well, obviously we go to employers and say, hey, this is a great idea. In fact, it was an employer benefit broker who heard about UberDoc very early on and said, you
Mhm.
have the Holy Grail. So what do you mean? You said you have the Holy Grail. It means like employees can get care, but
Mhm.
it's off the record. In other words,
Interesting. Okay.
it doesn't apply to utilization, because if the patient is going to pay cash
Okay.
with UberDoc, they get their say you twist your ankle,
Mhm.
right? Typically, you'd end up in a walk-in or an urgent care, maybe then to
Sure.
your primary, then an orthopedic, and that costs a lot of money. And
Mhm.
all those encounters are on the bill of the employer. But if you had the opportunity to just go to an orthopedic and pay $300 and have it taken care of,
Yeah.
then where's that record? Where's that
Mhm.
utilization? It's sort of on the patient that did it.
Mhm.
And so he's like, that's the holy grail. You have basically increased access without utilization increase. But if you're selling insurance to employers,
Mhm.
that's probably not a good idea. I mean, I'm just saying,
Yeah.
it's like if
Mm,
you're a
mm,
broker who's
yeah.
going to make money on those transactions, right?
Mhm.
Why would you sell it?
Well, that's a good point. Hopefully, forward-thinking brokers would think, "Okay, I'm reducing the utilization by adding this extra
Right.
tool," and that's ultimately what they should be paid
Right.
to
And at
do.
the end of the day, you're not eliminating insurance.
Yeah.
We're
Yeah,
not
of course not.
anti-insurance. We're just saying, what if we took all of those, like
Yeah.
those visits, those, like, those E&M codes that
Yeah.
clog up the ducts with transactions,
Yeah.
and they probably cost more to process and record.
Mhm.
We get a whole bunch of data on this stuff. What if we took all of those and just put them into a cash model, like through an HSA, and
Yeah,
say, here,
yeah.
this is and that doesn't limit the patient's access. It opens their network to anybody who will take
Mm,
pay. And that's
right.
really how I see this. And
Mhm.
the struggle employers have, huge. And in fact, I wrote something recently with
Mhm.
GI, who's an accountant, a forensic accountant out of Hopkins.
Mhm. Right.
And we wrote something, was in USA Today. It was supposed to be for Politico. It ended up in USA
Mhm.
Today about the subsidies, right? And one of the
Right.
things that we had realized is that the downward pressure on wages that healthcare benefits have
Yes.
assessed
Yep.
are enormous. And if you actually just look at the numbers from even pre-Obamacare, it's
Mhm.
flat. And so every time you open up a newspaper, you see, oh, this economy doesn't make sense. We have this great stock market, we have this, but the job market is sort of weird, and like the
Mhm.
wages are flat. It's like, hello,
Yeah.
hello. When 28% of a salary is going to a benefit that they are never utilizing, is that the best use of that money? Shouldn't that be going back into their pockets to, for a mortgage payment, or to put back into spending power? We've
Yeah.
literally hijacked the spending power of our employees into
Mhm.
benefits, and that has put a downward pressure on wages. And it's
Yeah,
not
no, I agree totally. We had an episode with Mark Cuban and a couple of guys from Stanford, Kevin Schulman and David Shanker the other day, and we talked about that. The average family premium these days is about $28,000, $30,000, plus the out of pocket maximum's another 20,000, so 50,000. You
I'm
know,
not worth that. I'm not that expensive. I'm just saying, because I can show you my books. I can tell you most doctors scratch their heads on this, because we
hmm.
all know what we get paid. So
Yeah.
all this world is like, all this money's pouring in for all of this
Hmm.
high cost of healthcare. It's like, oh my gosh, but we've only been cut. The
Yeah.
doctors and physicians for the last 15 years have just whittled down. I mean, to the point where in the last 4 years, it went below the waterline. Actually,
Right.
Medicare payments, it was like, so it's funny because when I'm in a group, I was in a group in Washington and a bunch of doctors there, and they're talking about don't
Mhm.
cut Medicare, don't cut Medicare. I raised my hand. I said, cut us to zero.
Mhm.
I said, cut us to zero and give the patient the money.
Yeah.
That's what I said.
Yeah. Oh, yeah, yeah, sure.
Just cut us to zero and give the patient the money and let them pay us, because
Right.
that would be so much smarter, right?
Yeah,
Because at this
yeah.
point, a $28 doctor visit, when it costs you $35 to bill it, is not an equation that it's a balance sheet that can't be maintained. And that's
Right.
why so many doctors have been forced into consolidation, meaning they have to
Yeah.
sell their practice or join like a private equity or to an
Mhm.
academic center, or a network. And then it restricts the access even more, because then there's even
Mhm.
more rules and regulations. So I
Right.
again, it more and more away from where medicine is, right?
Right.
The best medicine is technology. We can't
Mhm.
ignore it. It's
Yeah.
brilliant. It's breathtaking, actually.
Mhm.
AI is accelerating this in so many amazing ways. We need to get you got to take the boot off of us. You got to let the
Sure.
doctors be free to care
Mhm.
for patients the way we've been trained to do, because
Right.
we are all exceptionally well trained.
Yeah. Yeah. No, absolutely. So, along that same line, what do you think would shock employers the most about how specialist care really works? If
So I think that employers would be thrilled if they came
Mhm.
into my office and saw how we did things, if they went to the surgeon center that's run by the orthopedics, how things are,
Mhm.
right? I mean, I don't want to use the word better, faster, cheaper, because it's not really less, it's not skilled. It's like
Right.
you're just efficiency, right? It's
Yep.
about efficiency.
Mhm.
And those prices can be completely transparent. They don't have to be low. That's the one
Yep.
thing people are afraid of. It's like, oh, you're going
Mhm.
to stop paying me for this. Like already we're just struggling again because
Yeah.
of the expenses. But if you eliminated the middleman and that money went directly for the care, and
Yep.
if you made those prices competitive, and of course prices would come down for employers and quality
Mhm.
immensely. But right now employers are stuck, right? You sign on to networks, and those networks put big walls around your patients. And as soon as your patient calls the ambulance up some in a network hospital that isn't yours, there's a lot of issues, and this enterprise bills has not helped that issue. It's almost can be penalized to the employer. And then the next time when the employer sits down with their benefit person, they're like, oh my gosh, we got to make this network even tighter. And so
Yeah.
we're like choke holding our employees instead
Mhm.
of like, no networks, no anything, just make
Mhm.
it, this is what you have, and just partner with people who understand that. Um, I've always thought like the hospitals needed to be a lot more transparent and creative.
Mhm.
And if they didn't negotiate with anybody and just said, "Here's our price," here's Medicare, Medicaid, and this is our
Mhm.
commercial price. That's it. That's it. That's all it
Right.
is. But
Yep.
we're not going to bargain. We're not going to negotiate. If you just pay us that, we're happy. But you
Yeah.
have to pay us immediately. Like
Mhm.
no more going back and forth.
Right.
So in other words, there has to be something in it. On if we're willing to be transparent, then you have to trust us, and the
Sure.
authorizations have to disappear, and all the paperwork and all
Yeah.
the stuff that goes
Yeah.
forever, that really has harmed patients tremendously.
Yeah, I agree, and that's really where it is. It's the friction, it's the administration, it's the billing, it's the time to get paid, and the erosion. We spoke about how hospitals have really become the biggest collection agencies in the country right now.
Oh, for sure. And you remember though, and the weird part about this is that, Ralph, healthcare is like the number one industry in 47 out of 50 states, which is insane,
Wow.
right?
Yeah, yeah.
I mean, like it's terrible. We want
Uh-huh.
manufacturing, we want agriculture,
Mhm.
we want a
Yep.
diverse economy with technology.
Right,
But
right.
healthcare, I mean, but it's not
Mhm.
doctors and nurses, right?
Yep.
So it gets to be a bit of a challenge when so much again of the economy is
Mhm.
built around that.
Yeah. Yeah,
And that's why it's
absolutely.
so hard to tip the scales on it, because people
Mhm.
are afraid there's gonna be job loss. But
Right.
honestly, I would think that the economy is gonna improve when you put the healthcare dollar back in the hands of the patient,
Mhm.
and the only thing on the other side of that equation has to be a fair market price.
Sure. Yes, absolutely. Absolutely. And so the interesting thing to me, and I love your model, Paul. I think it's hitting a sort of a niche that hasn't been addressed. In your mind, what kind of signal, the fact that you went public, okay? Let's talk a little bit about that. What kind of signal is that about to you about where healthcare is going?
So just to put this in perspective,
Mhm.
the amount of women who
Mhm.
have taken a company from 0 to public is like fewer than 30, right?
Wow.
And even in the Canadian space,
Mhm.
on the Canadian
Right.
market. So this had to be a very good idea.
Yeah. Yeah.
I'm
Yeah.
just saying. I'm
Yeah.
not
It's
going to say I'm a
great.
genius. I just think that that's how good this idea is, right?
Mhm.
I should have rolled over 10 years ago, right? It
Mhm.
shouldn't have gone anywhere. I should have been able to, a surgeon in practice, and I still see patients. It's very
Yeah.
important to me to be frontline, to be
Yep.
for that street cred. I'm not asking a doctor to do anything that I don't do, right?
Mhm.
But the very fact that I could build this network of thousands of doctors, is it
Mhm.
that I'm a genius? No.
Right.
Did I have billions of dollars? No. I
Mhm.
have to be hitting on something that's missing in this system. And one of the things I've always done is I've always been system agnostic. Like, in
Mhm.
other words,
Mhm.
I've never excluded a doctor on the platform if I didn't say you had to be independent. No,
Right.
independent, specialist, academic, big
Mhm.
practice, small practice, employed, doesn't matter. Any one of them can be there can provide a seat in their waiting room for a direct patient, because I
Right.
believe I actually even coined the term DPO. And it's like, see, you
CPA.
guys can tell, would you want an HMO, a PPO, or a DPO? A DPO is a direct pay option.
Okay. I like that. I like
Did you
that.
like that? Yeah.
Yeah.
You can have it, Ralph. I mean, honestly, I coined the term because it's like, to me, it's like that makes sense, right? So then
Mhm.
a benefit person can say, hey, we have this new plan. It's called a DPO, and the way it works is like a lot of the premium is
Mhm.
on the patient. You have your risk category for your
Right.
stuff, and then you have your cap stuff, which can roll over into their accounts and grow.
Yeah.
And so that's how I view it. And the DPO, I want UberDoc is the first the first national DPO, right?
No, it makes a lot of sense. And, a lot of benefit brokers love, the acronyms,
Yeah.
PPO,
There
DPO,
you go, DPO,
DPC,
right? See, it's like
so
right
yeah,
there.
so it'll fit that.
And what's your
Now,
DPO? Cost plus is a DPO, green imaging, right? Like, we're
sure.
all just part of the first
Yep.
line of people who are going to be able to service the DPO.
Mhm. Yeah. I hope that this is the start of the market doing what the market's supposed to do, and then insurance or the payment mechanism wraps around that,
Right.
okay? Because the payment mechanism is not leading the change.
No, and there's no incentive for them to do it, but there is
Exactly.
incentive at the federal level because Medicare's bankrupt. I mean,
Yeah.
like, so they started Medicare Advantage to try to keep everyone permanently 64, right? Let's get half the
Yeah.
people over 65
Yeah.
old. But we know that, but there's too much. It's too much. It's too much of a heavy lift. But I
Mhm.
was like, we
Mhm.
don't need this heavy lift anymore. We needed that
Yeah.
heavy lift when we were in the hospital for 7 days in the
Mhm.
1960s, right? Back when the
Right.
physician's reference was
Sure.
a lock and key behind a
Mhm.
doctor. Now, you can push a button and everyone knows what drug, you can almost design a drug online, right? I mean, it's
Yeah.
like everything is just fluid and different. So
Mhm.
let's just say, like, that's too much of a heavy lift. Let's just simplify. And the simplest way to simplify is just start the dollar with the patient, whether
Mhm.
it's the insurance card that has a chip in it that you
Right.
go and pay your doctor directly on,
Mhm.
whether it's a Medicare card that becomes a Medicare Part B becomes a savings account with a
Right.
Medicare card with a preloaded amount of money that was yours, by the way. I'm
Mhm.
just saying that's your money, right? That's the money
Right.
you put in every paycheck. There's just ways to simplify it and and unify, like, the currency. We have like 1,000 different ways that the insurance companies talk to each other, right?
Mhm.
With all these different currencies, the change
Yeah.
healthcare, you need to make change.
Yeah.
It's like traveling through Europe before the euro. There's just a lot of expense
Right.
in constantly translating. Well, what's the cost? Well, it depends on your insurance. That's why it's so
Yeah.
hard to be transparent, because there's too many
Right.
moving parts,
Yeah.
right? But it's easy to be transparent if it's just my surgery's, 1,200 tokens,
Yeah.
whatever
Yeah.
that token is. And your employer pays, 100, 1,000 of that. Other employer pays half that. And Medicare pays,
Mhm.
500 of that. Like, was it
Right.
matter? It's just currency.
Yeah. And, I don't think there really is a price in healthcare.
No,
That's gone away. It's kind of like if you ordered something on Amazon and you had to wait 90 days and go through 4 or 5 intermediaries
you
to
wouldn't
find
order
out
anything
what
from
the
Amazon.
price was. Yeah.
We see we always said that we never set the price, Ralph. We set the transparency,
Right. Yeah.
right?
No,
That's it. We're just
exactly.
setting the transparency. When you see an UberDoc symbol in the window, you know that you're going to get a transparent price, that is
Right.
an option for you,
Right.
right? You don't need to use again, on our patients is they used to get in the
Hmm.
front door. It's like OpenTable, but I don't you get in the restaurant, we don't tell you what to order. If you need something else, you can pull out your insurance card and make the
Hmm.
relationship that now is in person. You've
Right.
seen the doctor, you've received definitive care. None
Hmm.
of this kind of like come back and see me the next day because it's
Yeah.
do this, do that first. I mean, we have so many series of billable events.
Yeah.
At the end of the day, just, don't bonus us for doing our job, just pay us, just
Yeah.
that and immediate payment. The immediate payment is really
Right.
important for doctors because
That's a recurring theme,
yeah,
immediate payment, because it certainly isn't the case with healthcare financing. One of the things that, personally that I see both as a third-party administrator slash consultant and as a patient is whenever you go into the doctor's office, the first thing they ask you is, "Where's your insurance card? What's your date of birth?" They don't even say, "Hello, how are you?"
that's right. Right.
And
It's all data, right? But the
yeah.
cool thing about UberDoc is, you just tell us your chief complaint,
Mhm.
right? And then you go into the office and yes, you fill out whatever paperwork they may have, but you don't have to put your insurance card.
Right.
You just walk in. I do a lot of vein screens.
Mhm.
People come to me for free. And this is one of the reasons I created UberDoc. I've been doing this for like 15 years. They
Mhm.
come in for a free consultation.
Right.
It's like the best visit of my day because
Mhm.
I don't have to write down a million things about you other than what's
Right.
important about you, your
Yep.
history and your physical. I
Mhm.
don't have to like say words that I know that the insurance company is going to need to listen to. I can
Mhm.
just be pure medicine, pure judgment, right?
Yeah, yeah.
And then if the patients need something, they pull out their insurance card or they state whatever, and so that's
Mhm.
where UberDoc actually came from was this concept of like just take good care of the patient, just
Yeah.
like make it simple. And if you take the middleman out of it, you take all that data collection out of it, it's
Mhm.
way more private, way more secure,
Right.
way more. And just it costs the whole system less
Mm.
because it costs
Yeah.
just as much to process a Blue Cross payment as it is to actually to put it in, right? To bill it.
Yeah. Yeah.
So it's like so at this point we're spending a lot of money on things that aren't related to medical care. And
Mhm.
all that money can go, I believe, again, back to the patient because that patient is at home after the knee replacement, right?
Right.
They're at home after any kind of operation. They get their cancer treatment as an outpatient. So
Mhm.
those families need that money there because
Yeah.
maybe they need to hire someone to sit with you.
Yeah.
Maybe they have to you take a few days off of work.
Mhm. So I'd like to talk a little bit more about home care, but before we get there, I think that most people, most employers and employees are scared of the cost
Yes.
because a lot of health plans have a split copay, $25 for primary care, actually a triple copay, $25 for primary, $10 for the minute clinic, and then $50 for a specialist. So they think, oh, the specialist must be really, really expensive. So
We
let me
all get
just
the
go
same E&M code. I'm just
to
saying.
yeah,
There's no difference
yeah,
in E&M code.
yeah. So,
It's not I would love it if we actually got more, but they got rid of consultation codes like 20 years ago. So
wow,
we actually
yeah.
all bill the same code, just to let you know on that one.
Yeah, and a surgeon, I mean, I sort of know some of this information, but I think the general public would be shocked to hear how much they actually get paid for a surgery. So, let's take a knee
Not much,
replacement.
I'll tell you. You don't wanna ask me that right now. Yeah, I'm in Massachusetts. It's
Yeah.
0. I mean, this case I'm about to do is probably 0.
Uh-huh.
They're uninsured,
Yeah. Well, and of course, we spoke offline earlier. Most doctors are really in it for the patients. They're
You
not in
know
it
what?
for the money.
So but you can't bankrupt us either. That's the
No,
whole
that's
thing.
true.
Because the cost of becoming a doctor, the cost of staying in
Oh,
practice,
yeah.
the amount of doctors who had to close their practices or sell their practice, consolidate is just bad.
Mhm. Yeah.
Everyone agrees. No one disagrees. Politically, 100% of politicians
Mhm.
agree
Yep.
consolidation's
Yep.
bad, but yet
Yep.
system still encourages it, enables it,
Mm.
and rewards it. I want
Right.
to see the system reward the independents as well,
Yeah.
and recognize that and do things to keep us,
Mhm.
because it ultimately is a risk, right? If
Right.
you're the only independent person in a network that's restricted around you, that's a way
Mhm.
to squeeze you out.
Yeah.
And that's why the direct pay primary care doctors are really
Mm.
smart, right? The
Yep.
DPC doctors are like, well, I just want to take care of the patients. But then sometimes then they're excluded from networks, which is ridiculous. It's like,
Yeah.
how are you, you know, just because you won't be in their sandbox? It's so wrong and unethical on
Mhm.
so many
Yeah.
levels.
Yeah.
It creates just more friction in the
Hmm.
system and worse outcomes. And let's just say we are number one in the world for bad outcomes in developed nations.
Yes.
I'm just saying, like, we don't win. We're
Hmm.
not in the Olympics on that. We're
Yeah.
not getting the gold
Yeah.
medal. We may be the most powerful nation and wealthiest nation on earth, and we have some of the worst outcomes for the amount of money
Hmm.
we spend in health.
Right. Well, my theory, Paula, is that because of all the friction of the payment, and because of all the waste in the, um, uh, uh, Kevin Schulman wrote a paper, and a sort of a branch of that was the life of a bill, the 43 steps that a medical bill goes through before it's paid, and all of the erosion during that.
But think of all the people employed.
Yeah, yeah. No, exactly. There's a virtual army, like the number of administrators in healthcare has increased by 4,800%, while the number of doctors 250% in that, 30 or
That's
so
why
year
the surgery
timeline.
centers do it so much better. When I'm in
Yeah.
my office, I mean, I'm certified nationally.
Hmm.
We get our certification, everything else, but I'm running all of this. We do
Right.
things based on our own compliance. You go
Hmm.
to the hospital, of course, it's going to be much more like bureaucratic. There's more rules, there's more
Right.
like things to do. And that's important when you're in
Hmm.
the intensive care unit, right?
Sure.
But
Yeah.
when
Yeah.
you're going to a doctor visit,
Hmm.
the doctor happen to move across the street from their independent practice into the hospital, and now
Hmm.
some $1,000, facility charge for the
Right.
same 20-minute visit.
Yeah.
That to me is that's unconscionable. That's not
Yeah.
right.
No, I
Um,
agree. I
and so,
agree.
but again, like you said at the beginning, there's a lot of
Hmm.
opacity. There's
Yeah.
not a lot of transparency. UberDoc is trying to do is just solve the tip of the spear, just be the
Hmm.
first step in the process, because I'm fully confident that many problems can be solved in that outpatient visit
Hmm.
in the doctor's office when you're talking to a specialist. When the people come to me and they're like, Dr. Rita,
Yep.
how'd you know that? It's like, oh my God, I like look at it all the time. I'm like, I'm a
Yeah.
genius. It's like, no, you do it for 30 years, you can pick it out of the crowd, right? You
Of
just know.
course.
And so there are so many talented people out there with so much experience. We have the brilliant young people that come
Yep.
out and join and train with us. I mean, we
Hmm.
are fighting for that to maintain the fact that we
Hmm.
can't be the best in the world again if we
Hmm.
just made the system, align in better alignment with
Yeah.
where medicine is,
Yeah. Yeah.
because
Yeah.
the price will resolve itself.
Absolutely. Yeah. Yeah.
And that's, again, always been my vision. Just make
Sure.
it simple. Make it simple.
Sure. Yeah. Simple is not profitable, though.
Actually,
So,
it could be very
well, no, you're right. You're right. It
actually,
could
it's
be.
more profitable because the money
Yeah.
it's
Yeah.
actually you eliminate the middleman, right?
Yeah.
So the
Yeah.
margin is better.
Yeah. No, I agree. I agree. I've had a lot of good discussions around that. Let's talk about home care. I mean, as a doctor, I think most doctors would agree that if possible, if the patient goes home earlier rather than later, unless they can't, you know,
Right.
and there are a lot of times when they can't, but if it's possible, is that generally a better place for them to heal and
Well, so certain things have changed,
Mhm.
like
Yep.
we do an appendix, they can go home the same day now,
Yeah.
I mean, it's, but other people that might have an infection, they might need to stay longer. Do surgery, a lot of times goes home, but think about one thing.
Mhm.
Old days when we admitted you to hospital and we kept you under my watchful eye for 5
Yep.
days, sent you
Right.
home, whether you lived alone or whether you lived in an assisted living with lots of people, or you had a 6th floor walk up, it
Right.
didn't matter because your outcome was going to be based on my watchful eye. Now
Mhm.
we send people home and we don't know. So your outcomes are more dependent on those social determinants than you think.
Mhm.
You could do
Sure.
the most perfect operation, but then the patient doesn't have, help at home to
Yeah.
be able to like, so that they end up, pulling a stitch or being more active, or they had to go back to work before they had to just
Mhm.
go back to work before you really wanted them to, because they didn't have any other way to like,
Right.
get by. So those are the issues that you have to understand. And I teach my residents that all the time. You can't just stop in the operating room, right?
Mhm.
You think about it. So I do a lot of wound care, and wound
Yep.
care is like I call the intensive care unit of outpatient care, because
Mhm.
your outcome with that wound is dependent on so many things, and including if they allow the nurse in, or
Mhm.
they don't have a nurse. And some of these elderly folks that are teetering on the brink because
Right.
they're okay when they take care of themselves when they're not sick, but
Mhm.
as soon as they have
Yep.
just something that they need,
Yeah.
when it exposes that.
Right.
And so I do think that our home care is that's where a lot of the attention should be also.
Mhm.
I think our nurses, teaching nurses are the best teachers of patients, and
Mhm.
we
Yeah.
undervalue that. We try to make them
Right.
prescribers.
Yeah.
Right?
Yeah.
Everybody's gotta be a nurse practitioner, but to basically be a billable event for the system, as
Sure.
opposed to being an incredible asset,
Yeah.
to be able to make sure that that diabetic understands they're taking their medication or the knee replacement has been
Mhm.
taught how to get in and out of bed, right?
Right. Right.
Like, I can't even enough how we under support that aspect of nursing.
Yeah. Absolutely. So people do use UberDoc then for home care.
Well, for home care, no, we're physician
Oh,
visits. We're physician visits. No, I'm sorry.
okay. But s so let me ask you a question though. If somebody went home after a knee replacement, after anything, and they're well enough to, is that something where, okay, yes, they might get home healthcare visits, but is that something where they could say, hey, listen, I want to talk to an orthopedic surgeon or a neurologist or something where they can actually talk to that specialist
So,
through UberDoc?
OverDoc is a visit to a specialist. That
Hmm.
most of them are brick and mortar, like visits in the office. We do have doctors that
Okay.
offer telemedicine. We're not
Right.
straight telemedicine. No,
Okay.
no, no. But that's actually one of the misnomers. Like, oh,
Hmm.
you're finding a doctor nearby available, you make an appointment, right?
Hmm.
But most, like, surgery is kind of a contact sport. Now we
Sure.
do
Yeah.
have doctors like an excellent rheumatologist. A lot of times those
Hmm.
they lend themselves to like a telemedicine model.
Right.
Psychiatry, things like that also lend themselves to a telemedicine model.
Hmm.
But for the most part, it's you got to get your hands on a patient, right?
Yeah.
To be
Yeah.
able to.
No, absolutely. Absolutely.
So yeah, so UberDoc is about getting you into a specialist nearby
Hmm.
available. So if
Right.
that nearby if a doctor has licenses in 5 states, like
Hmm.
our rheumatologist, and
Yep.
then nearby and available changes,
Hmm.
right? And if
Sure.
you can get that second opinion
Hmm.
and get your gout, resolved,
Hmm.
that's an amazing thing, right? Because you're
Yeah.
talking to someone who's seen it a million times and gets it.
Yeah.
So it's that level of, but for the most part, though, it's just again in a crowded office, being able to
Hmm.
someone tells you, you need to see a surgeon. I got 6 weeks. I need to see. It's like why? I need an
Yeah.
endocrinologist. I need to see one.
Yep.
Why is it 3 months?
Right.
Neurology. We had a patient on that used our platform who, was turned out of the emergency room. Was having something that they couldn't see her
Hmm.
at Mass General for like 3 months. She used an Uber
Right.
doc the next day, and he saved her life.
Wow.
Yeah,
Wow.
I realized she was about to have a stroke. It's like so it's just why? Because that doctor knew exactly.
Hmm.
He asked the 3 questions and knew exactly what the diagnosis was.
Right. Right. Wow. Well, that's amazing. Listen, we could go on for a long time, and I'd love to have you back another time so we can get deeper into this.
Absolutely.
But if people want to find out more about UberDoc, how it works, how would they get hold of you or get a hold of
Sure.
UberDoc
So
to
you
find
can
out
go
more?
to UberDoc, the website, uber-docs.com, and our ticker is APPT. So,
Okay.
yes, appointment. We're going to abandon
Uh,
the Uber part of it so shortly. At Paula at uber-docs.com. I'm very easy to find. Anyone
okay.
can reach out to me on LinkedIn as well. I love employer benefit people. I'm here for you.
Hmm.
I've learned a lot about this world, and I think we
Right.
are all in alignment about cost. And so
Hmm.
I will build any network or army for you of direct
Hmm.
pay specialists in wherever your employers are,
Right.
and also teach the employees about, like, again, a lot of it is about the consumer, right? Teaching
Yeah.
them, like, don't be afraid because we're credentialed, we're Navy SEAL, we got you
Mm.
covered. And
Right.
the best part about UberDoc is that, right?
Hmm.
It's like you're gonna get the best and you're gonna be able to afford it because ultimately you wanna democratize access to care, right? You want
Yes.
anyone
Yeah.
ever excluded from a specialist or what they
Hmm.
need for themselves or their child or their
Yep.
family because of an inability to pay or the
Mm.
fear of not knowing the price. So
Right.
that is what UberDoc, if
Fear.
anything,
Yeah.
we get rid of the fear,
Yep.
right? We're here to get rid of the fear. We can't solve all problems. We can't
Hmm.
guarantee the cost of that MRI or the cost of that
Yep.
surgery, but what we can guarantee is that there's no fear.
Hmm.
It is what it is. That is the price. That is the price
Hmm.
every time, every time.
Right. Excellent. Well, great. Hey, I love what you've done. I'm glad you went public. I'm glad you joined one of those positions of the top 30 women that went zero to startup. Great news. And it's a great sign of, I think what's happening in medicine.
I think so too.
Yeah, thanks. So I am Ralph Weber at The Benefit Whisperer. And if this podcast has been helpful, please pass it on, subscribe. And if you want to reach me, go to mybenefitssuck.com and you can get in touch with me. Thanks for being with me, and we'll see you another time.
Thank you.